Imagine being repeatedly researched, yet never truly heard. Communities often see millions invested in studies, but little meaningful change, leading to frustration and distrust. Today, we'll explore how embedding an equity lens into choosing endpoints and outcomes can ensure pragmatic trials genuinely reflect community priorities. This means redefining success with communities as partners, amplifying their voices as experts, and intentionally using data and methods to reduce disparities. Now, let's briefly review our objectives. First, we'll examine how power dynamics shape endpoint selection. Who defines trial success? Next, we'll discuss ways to prioritize outcomes meaningful to equity deserving communities, particularly within Canadian administrative data contexts. We'll then identify biases in administrative data and algorithms and strategies to address them. Finally, we'll explore methods to actively engage communities in selecting and measuring outcomes, enhancing both validity and trust. By the end, you'll have practical tools for embedding equity throughout your trial outcomes. An important step in choosing equitable outcomes is a bit of soul searching, reflecting on our own positionality as researchers. Positionality is basically understanding how where we stand in terms of culture, privilege, and power affects what we see as important. Researchers often come from very different walks of life than the communities they study. This gap can lead to well intended but inappropriate assumptions about the problems, needs, and even the desired outcomes for those communities. For instance, a researcher might assume that a community's top priority is reducing hospital days, when in reality, the community is more concerned about, say, feeling safe and supported when in the hospital and when sent home. Why do these assumptions creep in? It's human nature. We're each wearing a set of lenses tinted by our own experiences and values. If unexamined, these lenses can obscure the real issues. The takeaway here is to be conscious of our position and our biases. We need to continuously ask ourselves, am I framing this outcome based on my perspective or the community's? Let's dive deeper into a critical equity question. Who gets to define outcomes and whether those outcomes matter to those most affected? Traditional research often places this power in the hands of researchers or funders, not the communities experiencing the issues. That's a fundamental flaw. As the Chicago Beyond Guide reminds us, when community voices are not meaningfully at the table, we risk creating partial truths, measures that miss what truly matters. That's why the who cares test is so powerful. If the people most affected by the issue wouldn't care about the outcome you're measuring, it might not be the right one. Equally important is asking who decided this outcome? Were patients, caregivers, or frontline workers involved? If not, we need to revisit our process. Communities should help define success. For some, that might be reduced ER visits. For others, it could mean trust in the system, culturally safe care, or improved daily functioning. When we co decide outcomes with partners who bring lived experience, we move closer to full truths, meaningful results, and research that earns its place in the real world. Another factor that needs to be examined is the data we rely on. Pragmatic trials often use administrative data because it's convenient and covers broad populations. Much of our administrative health data comes from colonial systems that carry inherent biases. This means the very way data is collected and categorized might reflect the values and biases of those in power. For instance, if a community faces barriers to accessing care, many of their health issues won't show up in hospital or billing data, effectively rendering them invisible in our outcome measures. Consider a concrete example. An administrative algorithm for identifying depression that says a person must have at least 2 physician visits with a depression code to count as depressed. On the surface, that seems reasonable. But who gets excluded by this rule? Possibly the most vulnerable folks, those who can't afford to miss work for multiple doctor visits or who face stigma or other barriers to seeking care. They might be suffering from depression, but because they didn't see a doctor twice, the data would falsely tell us that they don't exist in that category. This is how well-intentioned data definition can inadvertently bake in bias against a group with less access to services. There are countless examples like this. That's why we emphasize truly knowing your data. We should always ask, why, when, how, and for whom were these data collected? By being aware of these, we can correct course, often by seeking guidance from those with lived experience, and avoid mismeasuring or mischaracterize what is happening in the community. Fairness and validity go hand in hand. Validity isn't just about technical accuracy, it's about ensuring outcomes genuinely reflect reality for all groups, especially those historically excluded. We all need to keep in mind that inequity isn't just about exclusion, it's also about disproportionate inclusion. Many equity deserving groups are more likely to be asked about high risk behavior, disproportionately increasing their visibility in those cohorts. Equity requires that we validate not just the numbers, but their relevance and reach. That's why it's essential to conduct equity audits. Check how outcome definitions perform across racial, gender, and income groups. If a risk algorithm works well for white patients, but under-identifies need in Black patients, it isn't valid across populations. But technical audits aren't enough. We also need community validation. Does the measure align with lived experiences? If people say, that doesn't capture what I'm dealing with, we must listen. Combining technical checks with community insight ensures our outcomes tell the full truth, not just a partial one filtered through systemic bias. When choosing patient-reported outcomes, we often rely on standard surveys and scales, but we must ask, are these culturally relevant for all groups in our trial? A measure that participants don't understand or value leads to poor quality data and disengagement. For instance, pain scales rated 0 to 10 might not reflect true pain levels across cultures. One group's 5 could be another's 8 due to communication norms or stoicism. Similarly, mental health questions like, I feel blue, might confuse people who don't speak English as their first language or fail to capture culturally specific concepts of sadness or anxiety. Always use culturally validated tools when possible, or perform quick validations with community input. Consider adapting questions, translating carefully, and addressing literacy levels with simple language or visuals. Ultimately, ensuring measures are culturally and contextually relevant produces more accurate data and demonstrates respect, increasing participant trust and engagement. Let's recap key points from our discussion. Choose meaningful endpoints. Select outcomes that reflect what equity deserving communities truly care about. Relevant endpoints ensure research findings are actionable and impactful. Address biases proactively. Data isn't neutral. Actively identify and correct biases in data collection, measures, and algorithms. What we fail to measure or measure incorrectly can perpetuate inequity. Validity through inclusion. Valid evidence requires incorporating diverse community perspectives. Community insights help us avoid partial truths, ensuring findings authentically represent reality. Community partnership is essential. Equity-focused research thrives on collaboration. Engaging communities at every stage improves science, ethics, and uptake of results, shifting power and creating real-world change. Embedding equity isn't an extra step, it's a lens enhancing the relevance and fairness of our trials. Thank you for exploring equity in selecting endpoints and outcomes. Remember, equity isn't a one-time task. It's a continuous lens for all our research decisions. Every choice we make can either reduce or reinforce disparities. Continue these discussions with your teams and community partners. Challenge the status quo, and let's ensure our research truly works for everyone.